What is going on? Um, the case of the day started out to be a joke. I was just going through some cases for just a teaching file that I'm putting together. And yeah, it was the joke was that I had sent over the image to cardiology on call. And I said, hey man, looks like you lost your remote in the patient after I'm sure he just saved the patient's life after having a STEMI. So that was the joke. He responded. We had a good laugh. And then I was like, hold on. This is actually a pretty good case. Full disclosure, I'm no cardiologist, obviously. I was hoping if I can get cardiology on call. He actually just finished up with a case. So he may kind of come in a little bit later and field some of your guys' cardiology questions. But as far as a radiologist standpoint, I can answer a few questions as far as what was on the image that I had showed you guys from Case of the Day. Once again, go to his page, check out the actual, well, if it is actually a remote control or not, obviously it's not. That'd be the smallest remote control ever. I have no idea what it would actually turn on. But figure out how to get to his page, check out what it is. It's a loop recorder, and he'll answer all your questions as far as what a loop recorder does and why patients have it, all that good stuff. I flipped all the images for you guys today, so everything should be in anatomical position. Let me know if it's not, but it should be. This is what I had showed you guys originally. This was the joke. This is not a remote control. This is a loop recorder. So this is a cardiologist, an interventional cardiologist who actually, for whatever reason, I'm not sure exactly why this patient needed this, whether it was for a STEMI, an end-STEMI, whatever it was, I'm not sure. But they're shooting the coronary arteries. They're taking a look at everything, making sure everything's nice and patent. If they had to stent something, they would have. Again, that's not my purpose for explaining the case today. My purpose was checking out this guy right here. What is this? I got a lot of mixed reviews as far as what this is. The most common thing that I was told was a stent. So I'm gonna work on terminology with you guys for a little bit here, but it definitely looks like a stent, right? This is something that you would expect to see this in, I don't know, we've seen esophageal stents. I don't know if you guys have. I see them all the time. Just had another case today. I can show you guys a case of that sometime later, but esophageal stents could look like this. They'll be a lot longer. Bronchial stents, sure. But this does look like a stent, right? Even a tip stent kind of looks like this. Mind you, this is a magnified view, right? Look at how big the heart looks like on the screen. When you actually break it down, this device is about that big. So remember, this is a magnified view. So it very well could be a stent. Our tip stents, they're not this short, but when I place the tips, in this kind of, scheme here, our tip stent would be about that long. So yeah, sure, okay, I agree. It definitely looks like a stent. It very well could be a stent. In a sense, it kind of is a stent, but let's take it further because that's what we like to do. We don't like to just stop at guessing what things are, and we like to actually understand them, right? So this is part of this is the aftermath of this is the result of a transcatheter aortic valve replacement. Other people call it a transcatheter aortic valve implantation. Fancy way of saying it, it's a TAVR, T-A-V-R, V as in Victor, R. So this is a TAVR. What happens to patients who have aortic stenosis, okay? Aortic stenosis, we talk about it all the time. You're gonna get this on step 1. You're gonna get aortic stenosis on the boards, whatever field you're in, you will hear about aortic stenosis. That's not to be taken lightly. Aortic stenosis, if it's severe, is actually a very detrimental ailment and can lead to a shortened life, a lot of morbidity, even mortality because of it. So it's not something to be taken lightly. There are different stages of aortic stenosis, and there's a grading system. As radiologists, we look at MRIs and we look at CT scans as well, and we can actually measure the opening of the aortic valve, and we can measure exactly the centimeters squared of what the opening is. Now, you're saying, What are these centimeters? Why do you measure them? So first of all, the aortic valve, you should have 3 leaflets, okay? So there's gonna be kind of one here, and then one here. So you should have 3 leaflets, and it's like a little fish mouth. When the blood pumps, when the heart pumps, it's gonna shoot blood out the aortic valve through the aorta. Let's go over a quick anatomy real quick, all right? You're gonna have the left atrium go into the left ventricle. The left ventricle is that thick, juicy myometrium that likes to pump, right? It's pumping all the time. Obviously, if it doesn't pump, well, you got bigger problems, right? So it's going to be pumping all the time. And then what is the valve that it's going to go through to get to the aortic arch? Is going to be the aortic valve. Please tell me you remember my little stupid mnemonic for how to remember the great vessels of the arch. A, B, C's. Big A, big B, big C, and then small little s, okay? The ABCs is plural, right? Aortic arch, brachiocephalic trunk, common carotid artery, and then subclavian artery, left, okay? So that's just a quick recap. So somebody gets aortic stenosis. I measure it. Say it's an 80-year-old patient. He's got the symptoms for it. The cardiologist did their examination. He's got the murmur for it. Yep, pretty concerned about aortic stenosis. We do a CT scan. I see that thing is calcified like crazy, right? That's a step 1 question. What's the most common cause of aortic stenosis? It's going to be calcific degeneration. It's the fancy way of saying that thing has a bunch of calcium around it, okay? So you can have an old patient. It's going to have a bunch of calcium in it. There you go. That's the most common cause. US Emily Dreams just mentioned bicuspid aortic valve. Turner's, yeah, there's a high association. And bicuspid aortic valve is I don't want to say common, but that's one of the big things that's seen with the younger patients that can cause aortic issues. Remember, bicuspid. Why is that a problem? Because the aortic valve should have 3 cusps, right? Just like we talked about. It's the fish mouth that opens up. 1, 2, 3. Should have 3 valves. Bicuspid, bad, right? It's going to cause some tightening in there. So I get my patient to get a CT scan, and I see the aortic valve, and then I see that it's not really opening up as much as it should. So that jet of blood from the left ventricle that's pumping, going through the aortic valve into the aortic arch, it's not that good, right? You're gonna get some turbulent flow. There's just not enough blood pumping through there. Obviously, if you're not pumping enough blood, it's not going systemically to the carotids, to the brain, down perfusing the rest of the body. That's obviously bad. So I measure the valves and the opening, and I tell you, and I'm gonna tell the cardiologist, because they all do this, before they want to do a TAVR, once again, for anybody who's just joining, what the image that I showed you guys earlier today was for a TAVR, TAVR, transcatheter aortic valve replacement. So what they want to know are all the measurements of the aorta down from the iliacs, going to the abdominal aorta, up through the aortic arch, and then down to the ascending aorta. So they want to know all those measurements. So I measure them, and I'm going to tell the cardiologist, well, it looks like that it's a mild case of aortic stenosis because it's about 1.5 centimeters squared. You don't need to really get bogged down on the numbers, but basically less than 1 centimeter squared, that's pretty bad. That's severe aortic stenosis. That's not good for the patient. So we measure it. A patient does have aortic stenosis. The patient has 2 options. Once again, I'm not a cardiologist. I'm not going to answer the questions as far as who is a candidate for transcatheter aortic valve replacement or open heart surgery, okay? That's up to the cardiologist, the cardiothoracic surgeon. They will make that decision for the patient, not for the patient. I shouldn't say that. Patients, they make their own decisions, but they will help the patient make their decision, okay? The one that we're talking about right now, just to recap for anybody who's joining in right here, this is what I'm talking about right here, right? This is your TAVR. Looks like a stent, right? In a sense, it kind of is. So what they're going to do is they're going to insert their catheter. So let's go from the very beginning. I'm going to I have a demonstration for you guys because I just realized I have a central line kit, because what interventional radiologist doesn't just have a central line kit sitting around right next to their table? This is weird. Sorry, guys. So here's my needle, okay? This is my 18 gauge needle. I'm gonna insert, usually we get a 22 gauge. I think this is larger than it should be. Usually we get a micro needle and we get into the femoral artery through the needle. Then I get a wire and I'm gonna insert the wire, this guy right here, and I'm gonna insert the wire through there. So now I have access into the femoral artery. You ask, do you need ultrasound? We're going to everything, by the way. I like going from the very beginning. You're gonna ask, do you need ultrasound to get into the femoral artery, or do you just do it blind? There's 3 main different ways that you can do this. One, absolutely, you can use ultrasound. You find the femoral artery, and then you get your needle and you nail it. Blood starts spurting out. You get the wire through, and then you do whatever steps you need to from there. Number 2 option, okay, I can basically palpate with my fingertips. I'm gonna have this finger more proximal, meaning more higher, or not more higher, that's bad language, right? Higher up towards the midline of the abdomen. So I'm gonna have this finger right here, and I'm gonna have this finger about a couple of centimeters lower, a couple of inches lower, okay? So now I can palpate the artery here, and I can palpate the artery here, and I know, obviously, there's artery in between the two, so then I'm gonna stick right between the two. That's number 2, how you can do it blind without ultrasound. Number 3, if the patient has a really calcified artery, I can basically turn on the fluoroscopy machine, and I can see that calcification. Because a lot of these patients, especially who are getting TAVRs, they have calcific degeneration everywhere, right? So they have calcium all over the place. So I can just look for that calcified artery, the femoral artery, just get my needle under fluoroscopy and just stick it, right? So those are 3 main ways that you can do it. So you get access with the needle, you put the wire in, you take the needle out, you put a catheter in, a dilator, all that good stuff, and you're gonna eventually have a sheath, a femoral sheath into the femoral artery, okay? I'll get back to why I am stressing sheath. Sheath. Remember that word. A sheath is a doorway from the outside world into the artery that basically literally has a door in it. It's a dam inside the opening of the sheath. So if you pull everything out, all the catheters, all the wires out of the sheath, blood's not going to be spurting out of it. It will, though it does have a valve so you can insert things back into there. So that's the sheath. You will hear about this all the time when you're an intern, that somebody left the sheath in the femoral artery, and you'll be confused as to what that even means. So we'll get back to that, okay? Remind me if I forget at the end. So basically, the cardiologist is going to get access into the femoral artery. They're going to get their catheter, the wire first. Remember, you always put the wire up first, and then you follow it with your catheter. So they're going to get all the way up, over the aortic arch, coming down into the ascending aorta, and they're going to basically get to where the aortic valve is. Because remember, right, now let's go the other way. Here's the LV right here. Here's the outflow, and it goes through the aortic valve, up the aortic arch, and go down. So the cardiologist is basically going to go the opposite way. So they get to the aortic valve, they're going to inject contrast, they're going to make sure they know where the coronary arteries are, the right and left coronary arteries, because you don't want to block them for obvious reason, right? So they know where the coronary arteries are, they do the measurements. Again, I'm not a cardiologist, an interventional cardiologist. I don't deal with the heart at all, but I do deal with the imaging afterwards. So unfortunately, I can't answer questions about how to actually, measure these things and place them. But they look where the aortic valve is, and they're going to inject contrast. They know where they are, and then basically through a couple of different steps. One, they're going to balloon open originally. I think most people balloon first. Some may not. And there's different types of these valves that they can place. So they're going to balloon open that valve that's calcified, right? Remember, it's calcific degeneration. It's all calcified. It's all bad and stenotic. So they're going to balloon that wide open, and then through another catheter, they're going to basically get that right here, this prosthetic valve, or this kind of stent looking thing. I'll show you right here, this guy right here. And basically the aorta, here is the ascending aorta, or the LV. No, let's say this is the left ventricle right here. And then the blood's going to be shooting out through here. This is where the aortic valve is. And then here's the beginning of the ascending aorta, and then the arch will come over here. So they're basically going to insert the catheter here. They're going to balloon it open, and it's going to balloon wide open. And the end of this, what we can't see on radiograph, it's not just this stent-looking thing. The end of it right here actually has 3 little leaflets. So it actually is a valve. So it actually closes when the left ventricle relaxes. But then when the left ventricle pumps again, it will pop these 3 little leaflets open. The blood can exit perfectly, and then the patient will be, resolved of his symptoms. Those calcified leaflets, those 3 calcified leaflets that we talked about before that cause the patient aortic stenosis, those are going to get pushed to the periphery and get wedged into the side of this new prosthetic valve. That's what this is. That's what interventional cardiologists do. Once they're done with this, they're going to take the catheter, the wire, everything out. And the reason I remembered, right, I'm talking about the sheath, okay? So they can either leave a sheath into the femoral artery, or they can remove it. You ask, why would you leave the sheath versus removing it? Cardiologists, not so much. But when you're talking about cardiothoracic surgery, interventional radiology, some other maybe vascular surgery, they may have a patient, for example, if I got consulted for a GI bleeder, okay? I can't really find the GI bleed. My attending are in there. We're squirting around the SMA, the IMA. We're injecting contrast. We don't really see the bleed, but we know from our CT scan or our nuke med scan where the bleed should be, the general vicinity of it. What we can do is we can kind of temporize that bleed. We have different agents that we can inject. One is this thick slurry type material. It's called gel foam. We can insert it through those little tiny arteries and it will tampen out the bleed. It will slow the flow to that area. And then it will actually clear up. That gel foam, that thick slurry will clear up in a couple of days, maybe about a week. But that gives the body enough time to repair itself in that week time. But what if I squirted around? I think I got the bleed. I'm not really sure. I have a strong inclination that this patient may bleed again. So what I'm gonna do, I'm gonna take all my catheters and wires out of that patient, but I'm gonna leave that femoral sheath in place. Remember, the sheath is a doorway from the outside world to the artery. So why would I take that thing out if I have a strong inclination that I'm going to come back tomorrow and re-embolize this patient or re-access that femoral artery? I don't want to keep re-accessing a femoral artery. That can lead to stuff that can lead to, first of all, it can lead to atherosclerosis. Secondly, it can lead to a dissection. Thirdly, it can lead to thrombosis. So there's a lot of different reasons why you don't want to re-access the artery. You absolutely can do it, but you don't want to if you can help it. That's why we leave a sheath in. So we send the patient up to the floor with the sheath. So you will hear these words. Patient came from cath lab, patient came from IR, patient came from wherever, vascular. The sheath is in place. It's in the right common femoral artery. And then they'll get sign out and give it to you, okay? So you'll say, well, what do I do with this sheath? I don't even know what to do with it, right? So that sheath, first of all, has to have normal saline flushing through there the whole time that it's in, okay? If you have a sheath in the femoral artery, you don't want that to clot up. So you need to have a pressurized bag that's sitting above the patient, and there's constant normal saline dripping through that sheath to keep that sheath flushed and clear while it's in the patient the whole time. If the saline stops, that sheath can clot up. It can lead to bad stuff, thrombosis, that kind of stuff. Number two, what else can you do with this arterial sheath? Well, if you're a nurse, if you're taking care of the patient, if you're a resident taking care of the patient, whoever you are and you're taking care of this patient, and you realize that there's a sheath in place, the patient's, first of all, by the way, if a patient has an arterial access, the patient's in the ICU. So if they have a femoral sheath in place, they're in the ICU because they're going to get constant monitoring. What you can do is you can insert another catheter through there and you have now an arterial line. What can you do with this arterial line? Well, you can check blood pressure the whole time. It's constant blood pressure monitoring. You don't need that blood pressure cuff that goes off every 5 minutes for the patient. You have constant blood pressure monitoring, which is good for the nurses. It basically says, hey, you know what? The blood pressure dropped to 80. I need to up the pressors. It goes up to about 100. Then it goes up to 150. And then the nurse goes, oh, I need to lower the pressors. Residents do this all the time. So you have that constant blood pressure monitoring, that constant feedback. So that's the arterial sheath. What else? What else about this case? Oh, closure devices. I want to talk about that real quick. I have, again, it's weird, right? I just got a bunch of stuff lying around. I know, I'm weird. I get it. Okay, so closure devices. You have a patient that just came from cardiology, just came from IR, just came from vascular surgery, wherever they just came from, somebody inserted a needle into the femoral artery. Now, how is that femoral artery going to close up? You have two main big categories as how far the artery is going to close up. And you pray to God that it's not just going to close up on its own because the artery is just going to keep squirting out, okay? Real quick, let's talk about an IJ, just as a side note. The IJ or any vein, any central vein, for anybody who's pulled a central line before, you pull it and you hold pressure for about 5 minutes and that's it. You're good to go. The artery though, that's a big difference. And the sheath that I had in that artery it's kind of juicy. It's a big guy. It's not this tiny little thing. So that's going to take a little actually pressure to hold that thing shut. So what I do is that as I'm taking the sheath out, I'm going to get my fingertips. Remember this, please. If you're a med student asked to hold pressure, you're an intern next year asked to hold pressure, you did the procedure itself as a resident and you're asked to hold pressure, do not hold pressure with this part of your hand or this palm part of your hand. Don't just jam down like that. Absolutely not. You get your fingertips and you hold down like this, and you smash that thing down, and then you're gonna start to let up a little until you feel that pulsation again. You don't wanna smash that down until you feel no pulse. That's not how you do it. Smash down, and then slowly lift up until you feel a little bit of pulsation. That's how much pressure you want to hold. And if it's a femoral artery, sometimes you got to hold pressure for about a half an hour, depending on the patient's coagulopathy, something like that. Okay, number 2, you just held pressure for 6 hours. I just gave away the next part. You just held pressure for 30 minutes, okay? You sent the patient up to the floor. Now it's your job. You're the radiology resident. You're the vascular surgery resident. You're the cardiology fellow. And you have to tell the nurse, you have to tell the residents upstairs, hey, how long does this patient have to lay flat? They have to have straight leg. You will hear these orders. You will see these orders written, straight leg for the next 6 hours. If you held pressure and there's no other thing that happened to close that artery, it's a 6 hour flat leg for that patient. They can't move their legs up and down. They can't sit up in bed. You're gonna pop that clot out and it's gonna fly off, and then the patient's gonna bleed into his skin. 6 hours laying flat if you held pressure with your fingertips, manual pressure. Number 2, this is the other thing. This is one type of a device, okay? There are many types of devices. This is the type of device that we use at our institution right here, okay? This right here is a plug, a vascular plug at the end. It's a complicated device. There's a whole bunch of other things to this. But basically what I'm gonna do is when I have my sheath in place, I'm gonna exchange that sheath out over a wire and put this bad boy in there now, okay? So I take the sheath out and I'm gonna put this guy in there through various steps. Obviously you don't need to worry about them. But what that's gonna do is it's gonna tamponade that hole in the artery, or arteriotomy. Okay, it's gonna tamponade that, it's gonna close it off, and then the patient can go up to the floor, does not have to have straight leg for 6 hours, but for 2 hours. So there's a big difference for the patient. 4 hours less of keeping that leg straight after they came back from some sort of procedure. They may wanna walk around. So there's a big difference in those two. The downside of these things, they can lead to a little bit of increased atherosclerosis at that site. That's just a quick side note. Any questions that I can answer for you guys? It all stemmed from a joke, which was this guy right here, transcatheter aortic valve replacement or implantation, however you guys want to call it. What else can I answer for you guys? Are we good? Oh, I think I had some more images. What am I doing? Man, I just talk like crazy. And this is what I think this is off the manufacturer's website. This is not mine. This is off the manufacturer's website. This is what it looks like. This is that stent looking thing that everybody's calling a stent. But these are actually the valves, the little leaflets. Do you see how there's one leaflet here, one over here, and one over here? This is actually what a real aortic valve should look like. 3 leaflets right here. So this, again, is what it should look like, but this is what it looks like in the patient right here, okay? This image I got off of Radiopedia. I got it written down here. This is what it looks like on a radiograph, and this should be flipped perfectly for you guys. So this is what you'll see. Now you know, whenever you see a chest x-ray and you see this metallic looking thing sitting over the heart that looks like a stent, now you know what it is. It's a TAVR. It's not any other stent in the pulmonary artery, in the bronchus, anywhere else, in the esophagus. It's a TAVR, okay? And it's this guy right here. Cool? What did he say the zoom in was? What do you mean by that, man? Zoom in, meaning this image was zoomed in, if that's what you're asking. This image is a really magnified image right here of the heart. These are the coronary arteries. This is a loop recorder, and this is the aortic valve replacement right here. What else can I answer for you guys before we call it? You guys all ready for the weekend? Anybody doing anything good? Should I have case of the day tomorrow? It's Saturday? Yeah, I'll have it. Good, got a thumbs up, appreciate you. Yeah, when cardiologists do their cardiac caths, they have to actually magnify a lot, which, I mean, it is increased radiation for the patient, but that's okay. Obviously, the patient can handle a little bit more radiation if they're trying to find a freaking occlusion in one of the coronary arteries, right? I think that's a pretty fair trade-off. If you saw an occlusion, again, I'm no cardiologist, but we can interpret, I don't interpret these, I don't dictate these at all. These are what cardiologists dictate, but they're basically looking for, this is a nice opacified artery, nice opacified artery, but they're looking for something that's either cut off and there's no distal opacification, or it's really narrowed and stenotic, causing the issues for the patient. I gave so many talks this week. Talked to med students today, talked to the medicine residents yesterday, had another talk earlier this week. I don't even know if I talked to you guys about Lexi scans and cardiology or cardiac stress tests. I don't know if it was you guys. But that's something, if it's not, somebody shout that out right now, then we will get into. I'm going to give you the quick and dirty about a Lexi scan or a cardiac stress test, the most common one that we tend to see, which is the nuclear med stress test. Quick and dirty, I equate it to a bunch of donuts and somebody taking a bite out of a donut. We'll get to that. I'll show you guys that sometime. What else? We good? All right, I appreciate you guys as always. I'm gonna try to upload this again to Instagram for the next 24 hours. I have no clue if anybody can tell me what is going on, why the sound is all jacked up. I have no idea. But once again, it's going on YouTube. Link is in my bio. Go check it out. Until next time, which is probably tomorrow, because I love doing this. All right, I'll see you guys.